Start and get started with this, and I'd like to invite our first speaker, a very dynamic and young Dr. Mrittika Sen from Mumbai, who will be joining us very soon in Chennai, and she's going to be talking about evisceration and enucleation. I'd like to request all the speakers to please stick to the given time, and we can take questions at the end of the session if we have time. Thank you.
A very good afternoon to all of you. I'll be talking about enucleation and evisceration, which I like to call losing a game but winning a battle. So to most people, these are disfiguring surgeries which deviate from the goal of vision preservation, which is for ophthalmic surgeons. But is that really so? Well, it depends on the indications and the techniques with which we can maintain both cosmesis, and in some cases, this may actually be a life-saving procedure. So the 4 M's that will help you to achieve a good cosmetic result includes operating under a microscope or a loop, ensuring minimal manipulation. You put in an implant whenever you can, except for specific reasons where you can't put it in, the choice of implant, and finally, all these 3 things together contribute to the motility. So coming to the indications for enucleations, these are irreparable trauma with no visual prognosis and prevention of sympathetic ophthalmia, a chronic painful blind eye, objectionable appearance with staphyloma or an atrophic or thicycle eye, and intraocular tumors, most common of which are melanoma and retinoblastoma. What are the things that we need to take care of before we start the surgery? First and foremost, check, recheck, and check the eye again. Dilate both the eyes and do an indirect ophthalmoscopy to confirm the eye before you start the surgery. Of course, these are even more important when we are operating in a case of retinoblastoma or an intraocular tumor. You have to ensure minimal manipulation. Do the myoconjunctival technique. I'll come to that. I'll show that in the surgery. Avoid any kind of accidental perforation and avoid using clamps for optic nerve. A long optic nerve is a prerequisite, which includes 15 millimeter. This is for intraocular tumors, specifically retinoblastoma. So some of the basic principles that would help you achieve good cosmesis ensures to preserve the conjunctiva, prevent any sort of buttonholing, and you do the peritomy very close to the limbus. Secure the wound in 3 layers, that is the posterior tenons, the anterior tenons, and the conjunctiva to prevent complications related to the implant. And you do an optimal volume replacement. So the implant has to contribute to 70% of the ocular volume. So this is a short video that shows the enucleation that was performed for a 3-year-old child with retinoblastoma group E in the left eye. In case of children, we like to do a canthotomy. This gives more space so that we can get a long optic nerve stump. The instruments that we use specifically for retinoblastoma should be blunt tip to avoid any sort of perforation. You do the peritomy flush to the limbus, and you do this we are operating under the microscope. The posterior tenons dissection is done again with a blunt tip tenotomy scissor. It is done in all the oblique meridia. After this, we start tagging the extraocular muscles. So the order is medial rectus, inferior rectus, lateral rectus, and superior rectus. We pass a 6-0 silk suture a little away from the insertion because that is the thinnest part of the globe. Then the muscle is tagged with 6-0 vicryl, about 6 to 8 millimeter from the insertion, and we cut. We can use RF cautery, or you can also use an artery forceps and cut it with scissor, but you leave a stump of at least 1 millimeter close to the insertion. Otherwise, when you're giving traction, the sutures can come loose. After this, we have to disinsert the oblique muscles, that is the inferior oblique and the superior oblique. Once that is done, we need to prolapse the globe, and I'll just fast forward to that. You prolapse the globe With this, what happens is the optic nerve is absolutely straight and you don't really have to pull on it too much. Then you go in with the 15-degree curved tenotomy scissor from the lateral side. You strum the optic nerve till you're able to touch the bone at the orbital apex. You open it just to enclose the optic nerve and you cut with a single cut. This ensures a long optic nerve stump, which you, of course, have to measure, and then you put in an appropriately sized implant. This is the closure of the posterior tenons. You do it with interrupted 6-0 vicryl sutures, and you take time for the closure because this is a crucial step that will avoid complications in the post-operative period. Following the closure of the posterior tenons, we need to reattach the muscles that we had tagged to their respective fornices. This is the myoconjunctival technique, and with this technique, it ensures adequate motility, which is almost equivalent to that of an integrated implant that has not been pegged. After this, we close the anterior tenons, again with interrupted 6-0 vicryl. And finally, we close the conjunctiva with a continuous key pattern of suture. So, I'll move on to the next slide. Post-operatively, whatever you take out from the globe, you have to send it for histopathology. That is very important because that decides the need for any adjuvant therapy. You have to follow up the patient for the other eye as well as for systemic evaluation, specifically for oncology cases. And then you implant the prosthesis after 6 weeks after allowing the socket to heal. So just a small bit about the size of the implant. The usual rule that we follow is the axial length of the normal eye minus 2 millimeter. But if we are wrapping it, then in that case, we need to subtract additional 2 millimeter. Apart from this, clinically, you can check for mooning intraoperatively, and you can also use sizers. Coming to evisceration, the indications in this case are a normal-sized blind eye, an enlarged or a staphylomatous blind eye, in case of endophthalmitis and panophthalmitis, or expulsive hemorrhage. Now, generally, this is a relative contraindication, atrophic or thicical eye, where you may not be able to achieve adequate volume if you're going by the traditional technique alone. These are, again, relative contraindications, history of prior trauma or via surgery, because the laser and the cryotherapy kind of keeps the choroid firmly adherent to because of the scarring to the sclera, and it becomes difficult to separate it out in one piece. A painful inflamed eye because of the risk of sympathetic ophthalmia, and a thicical eye because of an unknown origin, or if there is extensive calcification. Of course, we have to do a B scan with immersion and a UBM to rule out intraocular and ciliary body tumors before we decide on evisceration, a CT scan or an MRI whenever that is necessary. The implant in case of evisceration is smaller than what we use for enucleation. So usually for an eye of 24 millimeter axial length, we put in something like a 16 to 18 millimeter implant. However, there are techniques by which you can implant a bigger size, you can put in a bigger size of implant. That includes sclerotomy, that can be radial in the oblique meridia, or you can do a circumferential one. I'll show that in a video. With or without optic nerve transection, the 4-petal technique, and by these technique, you can either keep the implant partly or completely exteriorized. So this was a 38-year-old male with a blind eye following trauma. Again, the steps of peritomy remains the same. You try to preserve as much of the conjunctiva as possible. You need to do just the anterior tenotomy in this case, and you don't need to go up to do a very good posterior dissection. You do a stab incision, and then you take out the corneal button. Following that, you need to put in the evisceration scoop, and there's a cleft between the uveal tissue and the sclera, and you need to go all around, separate it completely from the sclera, and then take it out as far as possible in one piece.
I request you to please conclude.
Yeah, I'll just sum it up. And then, so basically, the steps are the same, but we have to treat it with absolute alcohol. And following the wash, you put in, so here we are doing a radial sclerotomy, but if the size is still not adequate, you can do what is known as a circumferential sclerotomy, where you go in up to the equator and you cut all around, leaving the muscle, so that allows you to cover a larger implant with the sclera, and then the closure remains the same as for enucleation. Thank you so much.
Dr. Mrittika, excellent video. In your first video, in case of retinoblastoma, is it instead of bipolar, if you cut by bipolar muscle, if that unfortunately that muscle, there is an early involvement on that particular muscle. So just not for you, but other for Shraddha Sanobar sir.
Right.
For other those, suppose your oncologist or your retina specialist is not so tuned to tell exactly, in such cases better we can use the scissor.
Absolutely, sir.
Instead of that
Yes.
take home message, if you are confident, so that's the thing, up to that mark, that muscle is not perfectly involved, and in such cases.
Absolutely,
But for
that
in
is-
general surgeon, the scissor one. Second, are you prefer evisceration or enucleation? For a say painful blind eye, what is there is a uveitis in the other eye.
So, in that case, after having ruled out all, if there is no intraocular pathology as such, evisceration works well unless we are, if the patient is at a risk of sympathetic ophthalmia, in which case we would then go for enucleation.
Sympathetic ophthalmia, as per the literature shows, even that trauma 7 days old,
Absolutely.
there may be a possibility at any time.
Yes.
So my view is that if there is a uveitis also, if you are not so much confident, it is a case of a sympathetic ophthalmia, already old case, long-standing case. Recently I operated one case, explained to all. So there is a if I do a enucleation also, is not possible to prevent if anything, and there is a chronic uveitis. So if you want, then we can go for evisceration,
Yes.
otherwise you can. But enucleation is not so easy in all that time.
Yes.
There may be a migration.
Absolutely.
Migration of ball especially.
Yes.
And other ball, there is a lots of issues. Thank you. Thank
Yes.
you. Very excellent talk.
Thank you, sir.
If you have any question from the audience, then for shortly 1 or 2 people.